Good morning, dear student. Today my topic is about laser in dentistry. I'm Dr. Harim Jafar Hamarashid. I'm periodontist. So today we are talking about definition, the history in brief, in very brief, and classification, uses, and possible hazards of using laser in dentistry. We are going through the definition. So each letter here is an acronym for a word. For example, the laser is the L1 stands for light, the A for amplification by stimulated emission of radiation. So the laser is an acronym. So that's the word laser means. The objective here, by the end of this lecture, you will be able to identify different types and uses of laser in dental field, and you should discover various serious hazards that affect by lasers, and recognizing most important control measures of laser hazards. The principal effects of laser energy is photothermal. This effect on tissue depends on the degree of temperature and corresponding reaction of the interstitial and intracellular water, because it's photothermal, it's photodynamic method. The laser wave will be affected by the fluid. So the reaction of the interstitial and intracellular fluid will affect the absorption of the laser waves. Laser energy is delivered with a thin, flexible fiber optic system and are well absorbed by melanin and hemoglobin and other chromosomes, but transmitted through water poorly absorbed in hydroxyapatite. So it's poorly absorbed on the tooth surface or on the bone surface, and it's well absorbed on the chromosomes, melanin, hemoglobins. That's why sometimes we use it for removing the melanin pigmentations and removing patches on the skin or on the gingival tissue. So regarding the history, simply the first Robi lasers was developed in 1960, but in 1965 Stern and Soganes reported in that a Robi laser, which was a Robi laser, the first one, could vaporize the enamel because of its high density and high wavelength of that laser, because we have two types of laser, one of them working on the soft tissue and the other on the hard tissue. And they thought that that laser, the Robi laser that was developed 5 years ago, could vaporize the enamel. So they adjusted the wavelengths according to the types of treatment. Regarding the classification, according to wavelength absorption, we have diode laser and NDIAC lasers and carbon dioxide lasers and erbium YAG lasers. So this is according to the wavelength absorption. I'll show you here a video on I'll show you from start. This laser is present in our college. I don't know nowadays they are using it or not, but before 3 to 4 years ago, I used the two types of laser in the college that was present at the college, but nowadays they removed it in the periodontal department. This is one of the lasers that's present. I just show you this video to know how it works, some kinds of laser. This is a Versa wave type. We have a switch power here. We have emergency power shutdown here. And this is the standby and the power button. Before using the laser, we are testing it to know if it's working or not. But if you see here, let me show you. Let me show you the exact position. Yes, this. As you see here, we have different modalities for different treatments. For soft tissue, for example, we have millijoule and herpetic, and for enamels. So we adjust the laser on that types of procedure that we want to work on it. And before we working on the patient, we should test the laser beam on a thin paper to see the cutting efficiency and the emission of light, and we test everything, the water. Sometimes we need a water when we use a high beam. This is me performing gingivectomy. This is before gingivectomy, performing the test on the laser. So this is simply the laser device. I just posted this video to show you how simply it works. So the types, also we can divide the laser according to the types of tissue working on it, to either soft tissue or hard tissue laser. And also we have non-surgical laser devices. We have laser devices that's not surgical. For example, we use some types of laser, just the thermal activity of the laser. We are using it, for example, as physiotherapy for the TMJs, to relieve pains and to treat the trismus. So we have soft tissue lasers, hard tissue lasers, and non-surgical laser devices. Regarding the uses, for example, we can use a laser for the treatment of canker sore, herpetic and aphthous ulcer of the oral mucosa, and leukoplakia. We can treat ulcers, we can treat canker sores, we can treat leukoplakias by using a soft tissue laser. We can use a laser for root canal preparation and pulpotomy and apicectomy by using a hard tissue laser. Also, in initial periodontal therapy, soft tissue lasers are used as an adjunctor. It's not used as a mechanical therapy. It cannot substitute the mechanical periodontal therapy using scalers and cavitrons. So it's an adjunctive treatment. Soft tissue lasers are used as an adjunctor and alternate in periodontal therapy to reduce the soft tissue inflammation, because it reduces the bacterial population photothermally, and in addition eliminate the antimicrobial problems like resistance, allergy, and side effects. Thus it can be used even in children and pregnant women, so it's safe. The herpetic lasers show significant bactericidal effect on P. gingivalis and Actinomycetum, Actinobacillus actinomycetum comitans. Laser pocket thermolysis uses the argon laser. This is a type of laser in conjugation with scaling and rotoplaning for reducing the pathogens within the pocket. So the herpetic lasers, which have a wavelength of 2790 nanometer, it can be used as a pocket treatment, periodontal pocket treatment, by killing gram-negative bacteria like P. gingivalis and AA, actinobacillus actinomycetum comitans. Lasers are capable of providing selective sub-gingival calculus removal to a level equivalent to that provided by scaling and rotoplaning. But I prefer not to use as a main treatment modality laser. It's used as an adjunctive one. Remove subgingival calculus without thermal change of the root surface. We have some beautiful and powerful types of laser that can be used selectively, subgingivally, without damaging the tissue, just working on the calculus subgingivally. But believe me, because of the thermal effects of the laser, you should be very capable of using, very expert of using the laser. Otherwise, you'll damage the soft tissue and periodontal ligaments, as well as the bones. If we just compare a scalpel versus laser, we have a relative ease of ablation of soft tissue with the laser. Hemostasis, instant sterilization. Actually, it's not a sterilization, it's a disinfection. Reduced bacteremia and little wound contraction. Reduced edema, minimal scarring, reduced mechanical trauma, less operative and post-operative pain. Increased patient acceptance, no or few sutures, and require no or topical anesthesia. Actually, this is what is written in textbooks, but what is important to know practically is that sometimes we use a scalpel or a blade, we gain a defined and perfect cut while doing surgery, while the laser, as a comparison, the laser use an ablation power. It is just does not cut the tissue as fine as blade. Okay, and these effects that we talked about, it is something not 100% emphasized. Why? Because in both of them we have wounds, but a little bit the laser is less painful, and the scarring area is minimum. But if you do a surgery perfectly with the scalpel, you may gain the same result as a laser. And in some surgical procedures, I prefer scalpel versus laser, because laser, it is just like when you work with the hand instrument and cavitron. The cavitron is blind. The laser power can't be controlled during the work. You should previously estimate the wavelength and adjust everything, but during the work you can't control the power, while the scalpel or hand instruments you can control it. It's up to your hands. And regarding the pains and other stuffs, it's relatively different, and it differs from one patient to another one. We can use it in gingivectomy, phrenectomy, gingivoplasty, removing of epules or pregnancy tumor, or benign tumors removal, gingival depigmentation or melanin depigmentation, eradication or removal of aphthous ulcer or healing of aphthous ulcer, coagulation of free gingival graft donor site, because sometimes we take a graft from palate and we need to minimize the bleeding that comes from the donor side, and we use a laser device as a cautery to just decrease the bleeding and obtaining a clean area. And soft tissue crown lengthening, we use it for, this is sometimes a synonym for gingivectomy. The root surface modification. In vitro studies showed that better fibroblast adherence after suitable herbemiac laser in eradication of disease surface than mechanical scaling alone. So we should have mechanical scaling while we do root planing, but with the use of this kind of laser, herbemiac laser, in the eradication of complete bacterial aggregation, it helps, it improves, it makes it better, but you can't use it alone for the eradication of sub-gingival bacteria. In contrast to focused mode, root conditioning effects with defocused mode CO2 laser prepare the root surface for favorable fibroblast attachment. That's to say, regeneration. So, what's the meaning of focused mode? The focused mode is when you put the laser directly in touch with the tissue that you work on, while the defocused mode, when you apply the beam from a distance to the area that you want to work on. So this is like attached and detached. This is the meaning of focused and defocused. So the defocused mode with the CO2 laser can regain fibroblast attachment after mechanical therapy. Nd:YAG laser irradiation result in reversible root surface change that includes surface pitting and carbonization along with unfavorable fibroblast attachment. So this is one of the side effects of Nd:YAG laser, but it is reversible. Some pittings, some carbonization, it will be reversed after, for example, 2 weeks or 1 month. Regarding bone surgeries, the effect of dental laser on bone is detrimental for osseous surgery, with the exception of herbemiacs and air, cry, and YAG laser. Fourier transformation infrared spectra of bone surface has shown formation of toxic byproducts that delay healings after herbemiac laser without water coolant and CO2 laser irradiation. Sometimes when you use a laser without water, it will affect the bone and causing necrosis and will delay healing sometimes. So I prefer 100% when you work on the bone, you should use a cooling system or water with it, because the thermal activity of the laser may cause osteonecrosis. Lower cutting efficiency as compared to conventional instrument and lack of depth of control are its limitation. So not almost always we prefer the using of laser. The reputation of laser is not as that we hear from other peoples. So it's selective. You should select it according to the case. For implant therapy, the advantages of improved hemostasis, fine cutting surface, less postoperative discomfort, and favorable healing in cases of peri-implantitis or inflammation around the tissues of implant, or peri-implant mucositis. Peri-implant mucositis is synonym to gingivitis around the implant, while peri-implantitis is a periodontitis around the implant. So we have the advantage of using laser in hemostasis, fine cutting surface, less post-operative discomfort, and favorable healing. Nd:YAG laser is contraindicated because of morphological changes it produces on the implant surface. As we talked about, it may cause pitting on the surface. And previous studies with CO2 laser have shown that associated risk with high temperature. It may cause carbonization and may interfere with the failure of the implant. Among dental lasers, YAG lasers at appropriate setting possess the best property for degranulation and implant surface decontamination without causing titanium surface change, as the Nd:YAG laser caused, as I told you here. So YAG is with the best or appropriate setting have a maximum effect on implant decontamination. We have another types of laser. We have diagnostic laser for caries and calculus detection. We have composite curing laser. We have optical impression like CAD/CAM. We have a laser for using for bleaching. So I show you here types of lasers, wavelengths and waveforms, delivery system, contacts, and clinical application. For you as students, I just recommend for you the types of laser and the clinical applications. These things in between are not recommended for you, and you just have to know the clinical application and the lasers type. The possible hazards. The laser hazards or the hazardous effect of laser depend on the spot size where we work the laser. For example, as I told you, if it is the implant surface, the size, the spot size is small or large, or it is serrated as an implant, or it is a bone, as a natural bone, it affects the spot size, affect the using of the type of laser, and power density of laser beam. For example, for soft tissue we are using 40 millijoule and 40 hertz, but when we are working on enamel, we should go to thousands of millijoule and hertz. So that's why the power density affect the type of your treatment and the duration of exposure. Actually, the more duration, the more thermal activity and the more possibility of the hazardous effect of laser. And laser operation sites. Are you working on implant or on the natural tooth? Are you working on the soft tissue or on the bone? So the hazardous effect of laser depend on these factors. The possible effects, we have ocular damage. For example, retinal injury, retinal burn, and other injury to sclera like cataracts. Sometimes some injuries may be permanent. An elevation of temperature above 37 causes cellular enzymes and protein destruction and coagulation necrosis, which affects the metabolic process. An escape of toxic chemical and gases from laser, for example, some powerful types like CO2 types. Sometimes the escape of fluorine gases, hydrochloride gases, toxic dyes and solvents. These will affect the types of treatment and the exposure area that you work on. Sorry. Flammable solids, liquids, and gases used within dental surgical setting can be easily ignited if exposed to laser beam. So you should be in an area, the working area should be safe. Sorry. Away from the flammable objects. Most laser systems involve high current electrical supplies. So electrical shock hazards or fire or explosion hazard is possible. We have two we have two main types of laser wavelength. One of them is free running, one of them is continuous. The free running is like a flash lamp. It will ignite and goes away, while continuous, the energy is emitted as long as the laser is activated. This can be controlled. It's a continuous wave, while the free running, it could be controlled. It's just like a flash lamp. And our laser in the college that I showed you in this the previous slide at the beginning is from that type, free running. All people with dental treatment room must wear protective eyewear, including the patient. The protocol for use is patient first. The patient should wear first and then the staff. Patient first on and last off. And he should lastly remove the eyeglasses. So this is a laser in dentistry in brief. Actually, it's a wide object, and it takes as many speech as possible in the matter of uses, in the matter of experience, in the matter of tissue that we apply laser to it. But just as this is just a hint for starting to know something about laser in dentistry. Unfortunately, in the periodontal department nowadays we don't have laser devices. Otherwise, I told you, I will tell you on these laser devices how it works and how we perform surgical operations on it. But I hope you get benefit from this lecture, and good day and have a nice time with the lecture, and I hope you understand it well. For any questions, I am ready 24/7. Thank you for listening.